Good afternoon, everyone. We're about ready to get started here. Today, it's my pleasure to introduce Bill Landers. Bill is the president of Orotech, a dental corporation specializing in periodontal diagnostics and anti-infective therapy. He's a leading expert on chairside and laboratory periodontal risk assessment technologies, including DNA testing, BANA enzymatic assays, bioscan phase contrast video microscopy, and cultures. He's presented hundreds of lectures and seminars at numerous venues, ranging from universities, government agencies, dental and dental hygiene schools, to local dental and dental hygiene association components. His lectures range from the microbiology and testing of periodontal tissues to immunology, systemic antibiotics, and anti-infective paradigms. Bill is certainly no stranger to IAOMT, and most of us have used his techniques and products daily, and it is just an amazing educational experience for not only myself, but also the patients. So I know this is going to be great, so my pleasure to introduce Bill Landers.
Thank you. Thank you. Is my mic on? You can hear me? Everybody have a good lunch? Okay, I've got the postprandial crowd here. So I'm required to read this disclaimer. I do have a financial interest in some of the products in my talk, and we'll be seeing some of them towards the middle end of the lecture. But I've titled this microbial tests versus notched metal sticks and blood, my derogatory term for the traditional testing tools that most dentists still use. And disclosure, as he said, I'm president of Orotech. I write some articles for RDH Journal occasionally too. There are no handouts for this meeting because they're just too voluminous. However, if you will provide me with your email address, or email me, and my email address is here, I will be happy to send you a link to download the full version of this presentation, which is 2 hours. This is an abbreviated version of it. And I also have several hours of other presentations on similar subjects. Okay, traditional clinical tests versus laboratory-based microbiological tests versus chairside microbiological tests. Those are the main subjects I'll be covering here. And let's cover the traditional ones first, starting with disclosing solutions. These are essentially worthless as a periodontal assessment tool, and radiographs. Pocket depth estimates is in parentheses because it is always an estimate, not a precise measurement. The standard deviation of reading on a periodontal probe is plus or minus 2 millimeters. So whatever reading you get is only accurate to 1 or 2 millimeters plus or minus. And bleeding on probing as well. Talking in specifics now, disclosing solutions. These are only staining the visible plaques that you see on the coronal parts of the teeth. Those surfaces are aerobic and are not capable of growing the organisms that trigger the pathological response that we see as disease. So you're only staining what are essentially health-associated bacteria. Now, as a patient motivation technique, sure, they're good for that, but don't rely on them as a diagnostic tool. Radiographs. Radiographs can't identify microbes either. What they are is a snapshot in time of how much damage has already occurred to lose the bone around the teeth in the past. It doesn't tell you whether they are currently infected, whether they're stable now and can be expected to retain those teeth for years and years or not. Studies that have looked at the correlations of pocket depths and bone loss radiographically with future loss of attachments have been able to find no correlations, zero correlations between any given amount of bone loss and what happens in the future. Periodontal probes. These were first developed in the 1920s and became routine in the 1940s. And of course, that was before anybody realized that periodontal disease was caused by microbes. They measure the sequela of the disease, not the causes. They're measuring the amount of bone that has previously been lost to the disease. They're not a snapshot in time as to how much disease the patient has, whether they're currently infected or not. On the subject of probes, Quiz. Which of these probes is the more accurate? A 2 millimeter marked probe or a 1 millimeter marked probe? Let me ask for a show of hands. Vote which one like probe A, 2 millimeters best? Which of you like the 1 millimeter probe B the best? That seems to be favored. Well, let's take that a little bit further. If the 1 millimeter markings are more accurate than the 2 millimeter markings, what if we double that? What if we put in half millimeter markings? Would that probe now be more accurate? Let's say we get even better. What if we put in quarter millimeter markings on that probe? Does that make it more accurate? Probe markings are illusory. They only give you the illusion of accuracy. Remember what I said earlier, you can only measure a pocket to within plus or minus 2 millimeters. That's AAAP, American Academy of Periodontology, gospel. So it's pure illusion to be putting millimeter markings on a probe. You can't measure it that finely. And it doesn't matter who's doing the probing, by the way. When I tell this to audiences, they usually says, oh yeah, that's those people. I know how to probe. I'm really good at probing. When they take calibrated examiners who have been trained in the same classes and set them loose on probings with force probes, the range is plus or minus 2 millimeters. So, periodontal disease, of course, is caused by pathogenic bacteria. And do you really think it's possible, even, to diagnose a bacterial infection with what essentially is a notched metal stick? It can't be done. It's only capable of measuring lost bone. So it's certainly not a tool for the 21st century that we're in. There are some misconceptions that I find even professionals have about pocket depths. Pocket depths are not disease. If you probe a patient and you come away with a 4 millimeter or 6 millimeter pocket, that doesn't mean that they have periodontal disease. The pocket is an artifact of past disease. It's sequela markings. It doesn't tell you anything about the current infective state of the patient. By the time the pocket is measurable, of course, the bone's already been lost, so it's not a prospective test for periodontal disease. It has no correlation with the future loss of attachment in multiple studies. And think about it. If you probe a patient and you get a shallow pocket, 2 millimeters or so, you assume that patient is healthy. You can't anymore because everybody starts off with shallow pockets, right? And at some point, those people get periodontal disease. So the disease originates in shallow pockets. They're not protective. Conversely, you can find patients with 6, 7 millimeter plus pockets that are perfectly healthy. The disease is arrested in those patients. They've learned how to maintain the microflora, and there's no expectation of additional loss. So no heroic periodontics is required in some patients with deep pockets. Bleeding on probing. This one really bothers people when they're told it's worthless. But since the 1980s, the scientific community has been well aware that there's been no correlation between bleeding on probing and future loss of attachment, which begs the question, why are you still doing it? You're required by law in most states to do periodontal probing, but there is no compulsion to do bleeding on probing. So this was the classic study in 1988 by Boyan et al. They looked at bleeding on probing at baseline and 3 months compared to attachment loss at 6 and 12 months. No correlation. What's more, no study since Boyan has been able to find any correlation between bleeding and future attachment loss. The reason is bleeding isn't measuring pathology, it's measuring capillary fragility, and there can be a myriad of causes for that. For instance, is your patient taking aspirin daily because they're cardiac risk? That will increase the bleeding rate by about 25%. You put that on the health history of the patient who take a daily aspirin. It'll certainly affect their bleeding rates. Probing force obviously matters. The ideal probing force is only 20 grams. Now, if you take your probe and you weigh it, guess what it weighs? 20 grams. So how many people, when they probe mandibular teeth, just basically let gravity help that probe go into the pocket? You always add additional pressure, you're probing too hard. There are so many complicating factors on things that can cause the gingival tissues to bleed that essentially it's worthless. Yeah, sometimes the bleeding is due to disease and inflammation, but so many times it is not. There's just no way to be sure. And the best illustration of that is this chart here showing false positives and negatives rates. False positive is the probability that the patient is bleeding, but there is no actual disease. And when we measure that, we find it's about a 29% rate. So almost 1 in 3 times when the patient bleeds, it's not attributable to periodontal disease. But what's worse here is looking at the false negative situation. This is the probability that they do not bleed, but they are already infected. And we look at that data, it's almost 9 out of 10. And that shouldn't really be surprising when you think about it, because the infection precedes the clinical symptoms that you see. What happens on the microbiological level happens long before the tissue is affected enough for the gross measurements that we can see clinically begin to appear. So, despite this being scientifically well known for decades already, most clinicians are still using periodontal probes and bleeding on probing as their primary diagnostic tool for periodontal disease. And this thing is skipping ahead without my even wanting it to. So, since they do not correlate, they're basically just a useless historical habit that we just do because we've always done it. They're legacy tests, not predictive, fraught with both statistical and operator error. And isn't it high time that we've moved into the 21st century of dentistry and moved beyond notch metal sticks and blood as a scientific tool for diagnosing infections? You can't detect infections with a stick. You actually need a test that can see whether an infection is present or not. And fortunately today, we have a number of very good validated tests that can check to see that infection is present or not. So let's talk about the microbiological test. And also, I think it's important to ask ourselves, why has the profession been so resistant to adopting microbiological tests when medicine has been gung-ho ahead of us for many, many years now? That's the first thing you do when you complain of a complaint to a physician is he orders tests, right? Not so in dentistry. Particularly in the fact that treating periodontal disease is very profitable for most offices. One of the reasons we've been so slow is it's habit. It's what we've done forever, and these things live on by themselves. It's what you do day in and day out in your offices. You've got to learn to break these habits, get out of the old mode that is preventing you from getting an accurate predictive diagnosis, and start looking at new techniques. And of course, what's called metathesiophobia, which is the fear of change. Laboratory tests. Those include anaerobic cultures and DNA tests. I'll be covering those next. There are a number of laboratory tests, starting with cultures, the oldest of them. These are laboratory tests. You need to take your samples and send them off to an outside laboratory. There are 2 main labs for that. I'll show you them in a second. And what they're looking for is anaerobic bacteria, several specific. They can culture about a dozen species of those now, and it requires very meticulous handling in the laboratory in order to do this. Microident is a DNA-based test. Again, you have to send the sample off to a laboratory. Oral DNA is a second DNA test. And BANA enzyme is a chairside microbiological test. It's an enzymatic test for the 3 members of the so-called red group that Sokransky is nicknamed. Those are the 3 most periodontal pathogens. And microscopy is the 4th microbiological test available. So on the culture front, advantages and disadvantages. First thing, and I think the most valuable thing that a culture can do for you, is an antibiotic sensitivity. So you've given the patient antibiotic A, antibiotic B, and they don't seem to be responding to therapy. Send in for a culture. They'll tell you or not whether the bugs that patient has are sensitive to those antibiotics. Moreover, they'll tell you which antibiotics they are sensitive to, because along with growing the bacteria, they plate them on plates with those antibiotics so they can see whether the bugs will grow in the presence of those antibiotics or not. As I said, they can check for about a dozen species. The disadvantages, it takes a full 2 weeks to do the testing, plus the transit time to and from the laboratory. Some of these bugs will not start growing in vitro until about 12, 13 days of anaerobic culturing. The cost is about $120 per sample that you send in for the tests. They cannot cultivate spirochetes. Those have proven to be extremely fastidious organisms. They don't know everything it requires to grow them in culture, but they have backup tests to look at for that. At the laboratory at Temple University, they use one of our phase microscopes. At the lab in California, USC, they used a DNA test to check for spirochetes. And why do they want to check for spirochetes? Because they have the highest correlation to disease progression. There are some 57 species of oral spirochetes, all of which are considered to be pathogenic. So where do you get your sample from? Well, these laboratories will provide you with a little testing kit, which usually consists of sterile paper points in a transport medium. And you insert the paper point to the full depth of the pocket, let it sit there for a minute, and then you pull them out and quickly move them into this transport medium, and then ship it off to the company. Overnight, if it's warm, because these things will degrade, in hot trucks if it takes several days to transport. Where do you want to sample? In the apical third of the pockets. Why is that? The reason is that as you go deeper in the pocket, the oxygen levels decrease. And the most periodonopathic bacteria grow in the most anaerobic portions of those pockets. So you want to get your sample from the apical third, not the supragingival. And these are just studies verifying that. And here are the two best culture labs in the country. OMTS, which is at Temple University in Philadelphia, that's directed by Dr. Tom Rams. And in the West Coast, OMTL, which is centered out of the University of Southern California, and the director there is Jürgen Slotz. DNA tests, advantages and disadvantages. One, they're very convenient tests to do. There's very little on your part that's required to do them. Like cultures, they can test for multiple species. And they will provide you with antibiotic guidelines. Now that's different than the antibiotic specificity testing that the culture labs do. There they actually grow the bugs in the presence of antibiotics to see what works and what doesn't. What the DNA companies do is they go to charts that tell you these bugs tend to be sensitive to these antibiotics or not. So it's a paper reference. And they provide you with a very nice printed out chart that you can put in the patient's record too, which is handy. Their disadvantages, expensive again, $99 to $130 per test, depending on which test you use. They're quicker than culture tests. It takes about 4 days total. You send it off to the lab does the processing, and then we'll email you the results. In the case of the microident test, they actually send the labs overnight to Germany, where their lab is, and process it there, and then electronically send the results back here to America. The microident test is made by Hain Diagnostics. They are Europe's leading DNA lab. Not only do they test for dental, but for all the medical diseases as well. Their US address is here in Midland, Texas, and there's their phone number. The other is called MyPeriopath, Oral DNA Labs, and they operate out of Minnesota, and there's the contact information for them. Okay, now we'll move on to chairside tests. These are things that you can do right in the office to get a microbiological handle on the patient. There are two available. One, the BANA enzyme test, for which my company is the exclusive source, and phase contrast microscopy. We're also pretty much the only game in town on that. This is what the BANA test looks like. There's a, I'm pointing with my fingers when they got electronic aids. This is the processor here. It's small. It's about the size of 2 cigarette packs. If you want to see it, there's one in the booth next door. And it operates with these test strips. The BANA enzyme is coated on the lower test strip there. It's very rapid. It only takes 5 minutes to process the test from start to finish. Very inexpensive. It's just $6 per test. And it detects all 3 species of the high-risk group, the red group. That would be Treponema denicola, Porphyromonas gingivalis, and Tannerella forsythius. Advantages of Benzyme testing, as I said, it's chairside, 5 minutes, and it detects the entire red group. And fortunately, it's just as sensitive as DNA testing is. They've compared the two head to head, and there's like a 98% correspondence in predictive value between the two. Actually, this is duplicating the slide before it, isn't it? And you read your results. I think it's on the next slide here. Oh, this is the DNA sensitivity. So that's a DNA test, assuming that's 100%, and BANA is like 95% as predictive as DNA test, very high. And then here's how you actually do it. You use your scaler to take the sample. And again, just like you would with the cultural assays, you want to do it from the apical third of the pocket, deepest sites of record that the patient has. You lightly smear the sample onto this lower test pad on the test strip, add a drop of distilled water to the top. Come on, slide, here we go. And then you fold it at the perforation. There's a dotted slot here, and the two pads fold together. And then you simply insert it into the BANA tester. That starts an automatic testing cycle. It will do its thing for 5 minutes, and a little light and a bell chimes to signify that it's finished. And when it's done, you just pull this strip out of the machine, discard the lower half, which isn't useful because the archival part is on the top here. And that's archival quality. That will stay stable once it's gone through the processor, so you can actually put that in the patient's record. And here is the way you interpret the results. Normally this is kind of a peach color, and after it's gone through processing, you'll get various shades of blue depending on what kinds and how many bacteria are present. It's considered to be a negative test, no risk, if it's colorless. It's the same original color that it was. If you get these faint blue markings, it's considered to be a positive test. There are pathogenic organisms present, not in especially high numbers, approximately in these ranges here, but it is considered positive nevertheless. And if you get these much darker spots, or whether the whole strip is darker, then that's considered to be a high positive response, and you'd probably want to treat that patient more aggressively. Any questions so far? Feel free to jump in anytime. In treating the infection, that's a little off topic for what I was going to be covering today. But if you'll see me over there, I'll give you what data I have on it. Yeah. Yes, it does. T. denicola is one of the spirochetes, so it's a representative member of the whole spirochetal family. They all grow under the same conditions. Well, I shouldn't say that. Some species prefer more anaerobic rather than less, but they're pretty close to each other. Yes. Good question. How many sites? What we suggest is that you go for the 2 or 3 deepest sites of record on the patient. If the deepest sites that the patient has are negative, you're pretty safe territory that the shallower sites are also going to be negative. But just to make sure you don't make the one pocket that's healthy out of 32 diseased ones, sample 2 or 3 pockets. And you can combine them on the same strip. No, bleeding does not interfere with the test whatsoever. Good questions. Yes, ma'am. Good question. Does the patient need to avoid brushing? No. We're looking at the bacterial component there, and that's not affected by what the patient eats. Remember, this is way down on the bottom of the sulca, so they're not nourished by food. They're being nourished by the blood and destruction products that are going on with the inflammation.
Do you ever have people maybe do a pre and post, like pre-scaling, post-scaling?
Yes. Do we ever have people test before and after therapy? Absolutely. That happens a lot, particularly while you're validating the test in your own mind. So scaling will knock down the levels of the bugs quite a bit, as much as 80 to 90%, just mechanical scaling. That's why we recommend irrigation, though, because that'll eliminate the last remaining ones. If you leave any of the bugs behind, they're going to repopulate the pocket, absent truly effective home care on the patient's part. So the object of professional therapy should be to knock those bugs down as flat as you possibly can while the patient's in the office. And if you're bringing a patient back for, say, quadrant root planing, why not sample the previously scaled quadrant while you're working on the next one, just to see, how well the patient's been maintaining that since their last visit to you. Okay. So this is just reiterating what I've already told you about the negative, weak, and strong positive reactions. Little quiz. You didn't think you were going to get away without a quiz, did you? This is a quote. At the beginning of treatment, the number of organisms in a pyorrheal pocket is enormous. During the course of treatment, the spirals diminish. When do you think this was published? It's hard to hear from up here, what? 1910. You're not far off. Good guess. And here is the actual date. This is published in JADA, 1925. And it's just ironic as can be that we were on the right track to all of this way back then. And somehow the profession got sidetracked into mechanical explanations and causes of disease. You know, Dr. Paul Keyes, who really started this whole movement, was senior dental researcher at NIH. He discovered the cause of caries, that it's strep mutans, and it always bugged him that a disease of the hard tissues, like enamel, was caused by a bacterium. You know, everybody thought a soft tissue disease was caused by overhanging fillings, calculus. You know, it never made sense to him. That's why he started investigating the flora of periodontal disease. The other chairside test is phase contrast microscopy. It has a number of advantages. Specifically, it is chairside. You can do it right there while the patient's in the chair. It only takes a minute to get the results, just as fast as you can mount the sample and put it on the scope. Yeah.
You only have to let it sit for 1 minute. You don't have to let it sit long.
Good question. She is, do you only have to let it sit for 1 minute or longer? It's viewable immediately in 1 minute. However, we do recommend that you let it rest about 20 minutes before you really take a look at it. Yeah, the reason for that seems to be that there's a lot of bacterial trauma associated with yanking these guys out of their nice, warm, organized sulcus and putting them on, what, an 80-degree slide, you know, so there's big temperature shock, and they kind of stop doing their normal thing. But if you just let them rest for about 20 minutes, they pick up activity. It's important enough that about 1 out of 3 slides will be different enough to change your diagnosis between fresh and waiting 20 minutes. Yeah. Of the BANA test? Okay, I'll back up for that. You should have asked your question sooner. Okay, here we are. There are the advantages. It's chairside, 5-minute test results. Detects all 3 members of the so-called red group. It's equally as sensitive as DNA, fully automatic, and inexpensive. And the disadvantages, it's a colorimetric test, which means you have to look at a color change, and that involves some subjective judgment. It's semi-quantitative. It can't tell you exactly how many bugs there. It can tell you a range of the bugs that are present. It only checks for 3 species, but they're the worst ones, and it is next to unheard of to have a periodontal infection that doesn't have at least one of those 3 bugs in it. And there's no written report. I mean, you just have to write in the patient's chart your findings. Yeah. Is it a what? Oh, the unit cost, it's $400 for the processor, and the test strips are $6 each. Fairly inexpensive. Okay. Yes, they do, and the fees vary, as you can imagine, you know, from practice to practice, urban, rural practices. In general, I get the feeling people are at the upper limit charging as much as they would for a set of bite wings, and at the lower end, someplace in the neighborhood, about $20 is the lowest fee I tend to hear. You know, you want to make the fee low enough that the patient doesn't feel you're, you know, gouging them, you know, with this test you want to do all the time now, but you know, the cost is $6, so, you know, you got a pretty good markup on those tests. Oops, now I'm ahead of myself. Okay, here we go. Okay, so I covered the advantages of the scopes. Oh, this is a big one. Microscopes can detect white blood cells. Why is that important? They're the primary inflammatory cell. So regardless of what other bugs may be involved in the infection, if you've got a high number of white blood cells, they're infected. You know, don't need to know any more than that. You know, they need treatment. And it can look at all 57 species, not just one of the spirochetes. And patient motivation, hands down. There's nothing that even comes remotely close. How many of you here already use the scopes in your practice? Oh my God, I'm preaching to the choir. Wow. Well, am I telling the truth that it's the best patient motivator ever? In the 80s. Oh, early adopter, yeah. To our unending chagrin, we're aware of a couple of periodontal offices, specialists, that are using our microscope not to diagnose the infection, not to determine the patient's ability to control the growth of the bugs in their mouth, but just to tell them, oh, you need surgery tomorrow. And the patients will do it. Do they see those bugs? They want them out of there. That's a more unusual reaction. She think they're going to go away if she doesn't visit you again. And it's cheap. The equipment cost is pricey. I mean, we were talking, 5-6 grand for the microscope, but the actual cost of the test is dirt cheap. Disadvantages of microscopes. They do have a learning curve. I mean, this is something dentists don't typically use, dental hygienists. So you do have to learn how to use a microscope, not that it's that hard. And the equipment cost, of course. This is just some of the studies in the literature validating the value of being able to, whoops, didn't mean to go through that fast. Validating that the presence of the bugs we see in the microscope do correspond to future loss of attachment. And you get a little movie here. For the uninitiated, the health samples tend to be boringly non-modal. Disease samples, the anaerobic organisms tend to be much more modal, and so there's this visual hustle and bustle going on there that even laymen can see the difference with. And I put this chart in here. I don't want to waste a lot of time on it, but people don't realize how fabulously income positive a microscope is in a practice. What most clinicians do is they test every recall patient because you want to see whether they're infected from visit to visit, and every new patient, of course, to get a baseline. Even if your testing fees are ridiculously, small, and you get, let's go on to something a little more reasonable. Say you get 20 recalls a week, and you're charging $25. That's $6 grand's income over 3 months you paid for your microscope. Patient motivation, we spoke of. I meant to take this slide out. I didn't want to bore you with the physics of what phase contrast is. This is what makes phase contrast. Bacteria are essentially transparent to light. The light just goes right through them. So with an ordinary bright field microscope, this is what you would see with an oral sample, and there's really not much detail to be seen there at all. What phase contrast does is it sort of optically stains the sample. So you extract information. It's just like playing with the KVP on an X-ray. So you take this same sample and swap over to a phase contrast lens, and you see this. So it pulls detail out that simply you would miss with an ordinary microscope. Here's how to do it. Actually, I went through pretty fast. I think we'll cover each of those in separate steps here. So the first thing you want to do is put out a piece of glassware. Always use new glassware. Never try to reuse it. There's always some residue left that's going to affect what you're seeing. Was that a question? No. Then you always handle by the edges so you don't get anything on the actual surface of the glass. The thickness of the cover glass turns out to make a difference for phase microscopy. You always have to use something that's called 1.5 thick cover glasses. In glassware, thick is a measurement like millimeters or inches. It's 1.5 thick is the thickness of it. You put a drop of OraPrep on the new slide. OraPrep is an artificial curvicular fluid that we developed that keeps the bacteria happy and alive for gee, most of the day if you prepare the slide correctly. And it prevents the cells lysing. If you put them into ordinary tap water, the white blood cells will break up. And things you never want to use, distilled water. People somehow think that's pure, it's going to be better. It's awful. The only application for distilled water is, you've treated the patient, you want to show what a wonderful clinician you are, make the next sample up in distilled water. It'll be there's nothing to see on there. And this is why what OraPrep does. It equalizes the tonicity of the solution to that which the subgingival organisms expect to find, so they're happy as pigs. Now, so you place the OraPrep, just a single drop, then you pull your samples from the various teeth in the single drop, because if you want to, you can put different drops on there and track, tooth by tooth what the flora is. But for practical purposes, you really have to treat all the mouth if even one tooth is infected, because these organisms are going to translocate and recolonize anyway. So pulling the sample works for most people. You want to keep them fairly intact as you put them into the sample. Disrupting them, you lose some information that you can get from the sample. And just like the other tests, you want to get your sample from the apical third of the deepest pockets that the patient has, 2 or 3 of them. Avoid calculus, that'll prevent the cover glass from seating closely enough. And then you just tease your sample gently from your curette or whatever into the drop of the OraPrep. And then the last step is you put a cover glass on it. And the best technique for doing that is to put it at an angle and then just let it flop down the rest of the way. That'll trap less air bubbles into the sample. And then the last step is you turn it upside down, compress it a little bit by just pushing on it once with a mirror handle or something, and then adding some OraSeal to the 4 edges of the slide. And this is what keeps the sample alive for hours and hours and makes it visible. Also, if you ever don't put OraSeal on a slide, you probably notice these rivers rushing through, underneath it. OraSeal prevents that from happening too. You haven't sealed it perfectly. Yeah. So you've got an unsealed gap and evaporation's happening there, and the whole water column's being pulled out that way. Yeah, it's sealing. Yeah. No, we investigated all kinds of things, and that's the best solution we were able to come up with. You could, it's kind of messy, but you could use Vaseline, put a bead of Vaseline or a smear of Vaseline along the 4 edges. That might work. In fact, I know it works, so you could do that. Don't use fingernail polish. That's acetone-based solvents. That'll kill the bacteria. This was the best compromise we could find. The solvent on that is toluene. And as I said, we eventually settled on that because the bugs didn't seem to be bothered by it. And answering your questions. So, what do you see when you look on a microscope? Well, one, and importantly, is the white blood cells, the inflammatory cells. So we're always looking for how many white blood cells. Not that you have to count them, 1, 2, 3, 4, 5, but you do want to see, they're few in number, there are lots, they're too many to count. Treponema, the genus for the spirochetes. Any and all spirochetes are considered risk factors. The smaller, tinier, looser ones, they grow in more aerobic conditions. They're not as big of a threat, but when you get these long, thick, tightly coiled spirochetes, they grow in the most profoundly anaerobic conditions, and they're considered to be highly inflammatory. Candida, yeast, by and of themselves, they can trigger an inflammatory reaction. Where you usually see that happening, though, is in the case of superinfectors, where you've given the patient a systemic antibiotic and it's wiped out their bacterial competitors, and then you get an explosion of the yeast population. But if that happens, yeah, the yeast can trigger an immune response. Trichomonads, these are animals, cells, one-celled animals. They're not causal, but they're always present in the highest risk cases just because of the debris and destruction that's going on there. They've got a free lunch going on. Same for amoebae. And I'll show you what these guys look like. Red blood cells I put on there, but they're not important diagnostically. It's just something else you can see on a microscope, but that's just microscopic bleeding that's going on in the pocket. And as you know now, bleeding doesn't correspond to anything. So the epithelial cells are not significant, but if you don't see some in your sample, you haven't gone deep enough in the pocket, because you should always get some epithelial cells. Non-motile rods, this is what you would find in a healthy sample. Very quiescent, few numbers of white blood cells, no spirochetes. There's a 3D image of what spirochetes look like. And fortunately, they just are easy to spot diagnostically. These are the ones I was talking about that grow in the more anaerobic conditions. And these little small, wispy, thin spirochetes are relatively recently gone anaerobic sites in the mouth, fairly young. And as the conditions, as they lay undisturbed and the oxygen titer gets lower and lower, you start finding the profusion of these larger, thicker species. So you can almost do a differential diagnosis of how long that biofilm has been in place undisturbed by the types of spirochetes you see in it. Organization. This is fascinating. I don't know how many of you have seen this on slides, but when the density of these bugs gets to a certain number, they sense biomarkers coming from the other spirochetes. They know relatively there's a few or a lot of other of my brethren around, and it switches on and off genes in these spirochetes that change their behaviors. So instead of being planktonic and going off in all these directions independently as individuals, they start behaving cooperatively. So you see these formerly free-living spirochetes that start lining up shoulder to shoulder with the spirochetes on their periphery, beating in unison. So I got a better diagram here of how they organize. So you get individual spirochetes, and they start lining up, synchronizing their motion. And it's not this, rather than them going out and having to find things one by one, they're creating a big fluid flow with this pumping action that gets all the nutrients and stuff to come by them instead. More efficient. So I apologize, it's hard to see these in projected slides, but these are spirochetes. And obviously the reason why patients get really motivated when they see these things are in their mouths. I'm sorry, I couldn't quite hear you. Were they eating? Oh yeah, yeah. It's not uncommon at all to see this kind of behavior in a patient. It looks clinically fine. Yeah, there you go. Yeah. I mean, you just can't tell clinically who is infected and who is not. Our eyes are just not sensitive to see bacteria. But yeah, these are the kinds of things that precede the frank destruction of the tissue that you see in that order. There's nothing river-like flowing from place to place. It's analogous to wind blowing on a wheat field. You see these waves going across the wheat field. It's just because of the synchronicity of their motion that you see these waves. And what do spirochetes like to eat best? White blood cells. Now, the irony of that is that the white blood cells are supposed to be eating the spirochetes. You almost never see that happening on a slide. But these gangs of spirochete thugs will run around, they'll find a white blood cell, and just like a sperm on an ovum, they'll keep punching and punching away, and finally they'll burst the membrane, and it's like sharks at a feeding frenzy. Okay, motility. This is not nearly as important as whether they're spirochetes or the levels of white blood cells, but it's yet another factor that we see in health versus disease. We've gone too far here. So, is this a short movie? Oh, right. We're back to spirochetes again. Here we are. Yeah, it's just 7 seconds. These are what we call gliding rods because we don't know what species they are. We can't grow them yet. But we see this type of behavior in advanced infections. So you see those large, thick gliding rods that are, moving like steamships through your sample. They're associated with disease too. Well, those particular ones weren't Vibrios. Vibrios have a comma shape. Yeast, as I said, can be inflammatory by themselves. Yeast are what are called the pleomorphic organisms. They have two different growth phases and appear distinctly different microscopically. When they're growing, they put out these hyphae, very easy to recognize those. But when conditions aren't favorable to them, they shrivel up and form little buds or spore-like structures like you see here, which can look a little bit like red blood cells. So, sometimes you're looking at them and don't realize what they are. And then the buds produce smaller buds, daughter cells. And because of the similarity, they're hard to pick out. But at their biggest, they're no more than half the size of a red blood cell, yeast's red blood cell. And here you have yeast hyphae, as seen microscopically. This is a live picture. They're not very active. And now for my all-time favorite. That's she said. Everybody says the same thing. They look like little rats, little mice. They're typified by this long axial style, and these usually have 4 super long filaments. They're always whipping around here, and an undulating membrane here. This is a one-celled animal, like amoeba. So there's some debate in the medical community whether this is a separate oral species of trichomonad or whether, in fact, it's the same one that causes trichomoniasis in women. Now, we don't think that this bug is causal, but again, because you only see these in the most advanced cases where there's a lot of destruction and they're feeding on all of that detritus and side effects of the breakdown of the tissue. So if you do see amoebae or trichomonads in your sample, you know that's a long-standing infection. It's been there for some goodly amount of time. And here's what they look like under the microscope. And you see rats, right? But I swear, if you could find one about the size of a collie, it'd make a great pet. This is in the biofilm. Not to my knowledge. Maybe. I'm not positive on that. But where we see them is in the organized biofilms that you scrape off the surfaces of teeth. And there you can see that undulating membrane. This is at 1000 magnification. They're just, I don't know, I find them fun. Amoebae, one of the classic microbes, one of the first to be identified by Van Leeuwenhoek. When they're moving, they're easy to identify because nothing has this protoplasmic flow type motion. By the way, they actually dissolve their cell membrane and their guts kind of flow out there, and then they reform it up again and then drag their other part back along behind them. And they can go in several directions at once. Sometimes you'll see it in amoeba, one part's going this way and the other part's going that way. They're just responding to chemical messengers on that side of the membrane. Now, when conditions aren't favorable for them, they too will ball up and can be mistaken for white blood cells. But there are a couple of tip-offs. One, they are always considerably larger than white blood cells. And they have a lot of stuff going on inside the cell. White blood cells will have 2 to 3 dark lobes to the nuclei and nothing else. Are we up on time? Okay, I'm almost done, in fact. So here are some humongous amoebae moving in a sea of spirochetes. And white blood cells, these are very good indicators for periodontal disease. They're 12 microns in diameter, and that's what they look like microscopically. And we're done. Yes, thank you, thank you. Oh, my email address? It's B for Bill, Landers, Landers, at Oratec, ORATEC.net. And if you send me an email and just say, I want your courses, I'll provide you with a link to download them from Dropbox. Be a little patient. They're humongous. They're very large PowerPoints. Well, thank you all for coming.
Thank you.